Today we are in the MCPS class, and this class is not meant for MCPS, but this class is for MPH, MSPH, even MBBS, BDS, and MPhil, and even the PhD people can also benefit from this class. And this is first time that we are running regular MCPS classes in Israel University. My students are in front of me, and I will just welcome them. Dr. Abdul Wahab, Assalamu alaikum. So nice to see you. Next slide, please. So from this chart you can see that we have already covered the epidemiological study cycles, in which how they will start from a case series, case report, then cross-sectional, and then we will move to the case control, cohort, and ultimately the clinical trial or randomized controlled trial. So these were the few cycles which we have already covered in the first lecture. So this is second lecture, and you can see that sample without disease and sample with disease. So you have to select first a sample which is a kind of research formula or whatever available. Sometimes there are different sample methods, there are different names. It can be random sample, it can be simple random, it can be stratified, and it can be even the convenient sample if the situation is not favorable and you don't have this. But next please. So you can understand the direction of the case control is from present to past, and this arrow is beautifully showing you that this study starts in the present and goes back as much as possible. It can be 1 year, it can be 10 years, it can be 20 years. So it depends upon your resources and your will and the type of study. And cohort study is basically if you will turn this from present to future or forward, then it will become, and almost the other parameters are the same, and we call it cohort, and here we call control group, but there we will call a comparison group. Next. This is another view which is very busy slide, but you can see that there are certain cases with a red or orange color, and there are same situation, same locality, same people, their height is same, they are eating the same things, but some are sick and some are not sick. So case control starts with the sick people and compares with the non-sick people are without outcome for our study. Next please. So this is a MCQ which shows that if you are conducting the study who had an outcome or event with those who are without outcome, then what type of the study will be? The answer is in the red line. It will be case control study. And here we compare the second question is a carcinoma patient with smoking and without carcinoma but with smoking. And then we compare it, so this type of study here also will be case control. And then the last is which of the following are not advantages to case control study. So they allow to study multiple outcomes for single risk factors. This can be calculated from the cohort study, not from case, because you have already taken one parameter, suppose cancer, lung cancer. So you will follow the same cases. So you will not have the multiple factors. So here this will be following are not the advantages. So you will not have a multiple outcomes of the study. So this is not an advantage or good point for that. So these three MCQs are there. Next please. This is one of the important slide, and you can see that the direction of the study is same as I have already told, that the exposure is in the past and disease is in the present. So your study starts from disease and goes time to the exposure, and some people will develop disease, some people will not develop disease. So the cases with disease and control without disease, but the source population should be the same. Both should be from the base population or the same population or from the same situation. Suppose in Pakistan you are conducting a case control, then your control should also be from Pakistan, not from other countries, because other parameters are the same. Next please. These are the few things that every study will follow, be better, and last is the analysis, and first is the selection of cases. In between you have control selection and information on exposure. These are the two important things. Next. Selection of the cases, you know that if they are diagnosed in the hospital or through any test or through any clinical questionnaire, suppose mental health cases, normally they don't have such laboratory reports, but they are diagnosed on certain parameters and certain questionnaires. Next. And sources of, I have already told that population based, not biased by factors drawing patients to a particular hospital. So study should be mostly population based or based on the same population. And hospital clinic based cases easier to find and may represent severe cases. So this is a weakness of this. So only in a hospital you will have very severe or very sick people. The other people of the same disease may be in the population. Next. Selection of the control can be the postgraduate questions. So what is the criteria of the selection of control? First, they should be without disease of study, of interest. So what you are studying, they should be free from that disease when you are starting the study. Then they can become a control. But they should be from the same population or from the same family or from the same village or from the same district or from the same province. And there are other slides where the matching is important. Matching can be a group matching and matching can be a pair matching. Selection independently of their exposure status, and then you will ask the question whether you had smoking or not, tobacco use or not. Next week. So this is, I think, important. Facility based, population based and case based. These are subtypes or variation of this study. Next. Matching I have already told you. Next. Group matching and pair matching. Pair means case to case. Suppose one person is matched with the neighborhood person or from the village person or from some school. Suppose a student is a case for any disease which is your interest, then the same class or from same school you can select a boy of the same level of the same class. So this is matching, means you are giving apple to apple, orange to orange. Next. Selection data should be objectively, accurately and precisely, not vague, not just generalized. Next please. So this is the 2 by 2 table, and ultimately we will calculate the association, and that association is called odds ratio. We will come in the next slide. Next please. So how you will calculate the odds ratio? You can see that there is the odds. Odds means chances. Odds means chances of developing disease. If it is 1, then there is same chance between case and control, or there will be equal. But if it is more than 1, that means that the chances of the disease are more as compared to the control. This is the formula. Next, please. And if odds ratio is 1, then controls are same, exposure is not associated with the disease. It means 1 will not give you any good definition or good clue. More than 1, exposure among cases are higher as compared to the controls. And if it is less, then this shows that lower the control exposure is negative associated with disease. So if it is less, then it is a positive point that the disease or that factor can be not harmful but can be, suppose a person with exercise and less exercise and normal exercise. So if the ratio comes less than 1, it means that the exercise has a beneficial effect. Next, please. Biases we will discuss later on. Biases means the other things which study will face or they have entered into the study. It can be recall bias. The patients are already sick, many years have been in that disease, so they may not recall or remember the exact date, exact situation, how disease can be called. Next. Confounders are both with the exposure and the disease. So these are some of the important, when the disease has multiple risk factors which are related to each other. They look similar, but they are not the actual disease causing factors. Suppose a person is from Quetta and person from Hyderabad, and if he develops a cold in Hyderabad, this doesn't mean that the Quetta cold has come to the Hyderabad. It can be any other reasons or any other weather condition which has brought the cold in Hyderabad. Next, please. So, bias in analysis, sometimes you make mistakes or your data can be giving some wrong information or wrong direction or wrong conclusion. Next. Strength of the study, one is that outcome with long latency period, means having a long period. Suppose a short period disease will not be the important disease. Quick to conduct, requires comparative few subjects, and multiple exposure or risk factor can be examined. So exposure can be examined if there are multiple exposures, not multiple diseases. Next. Weaknesses susceptible to recall bias, memory bias. I have already selection of inappropriate comparison group, rates of disease in exposed and unexposed you cannot be determined. You can just see the association, not exactly that what percentage of diseases is the case control and what percentage. That will give you the relative risk, which is not the case here. Next, please. So this is a summary which shows that design elements, matching, odds ratio, bias, distance, and weaknesses we have already covered. Next. So these are the few references. So if Dr. Hussain Bashkolati YouTube channel has given you some of the insight about the case control, please like it, subscribe it, share it, and this is in the public interest and in the interest of this community medicine, so that the information available in this class is available to the who are not even in this class. So that will be a public service. That is the main purpose that we are recording this. Thank you very much.
Advantage to case pest control studies. They tend to be less expensive. They are feasible for rare diseases. They are able to study multiple outcomes of our single risk factors. They are good for disease that has a long latency period.
अच्छा एक सिर्फ हाँ